We start with the first plenary roundtable on philosophical diagnosis. As you know, this is a controversial topic because much of philosophical practice and specifically philosophical counseling has developed in opposition to medicalizing and the diagnosing of many psychological states. But we have a situation where we need to sort of discuss this in perhaps somewhat different terms. So Peter Hartelo has proposed this roundtable to take up this issue and see what we can do with the concept of diagnosis and how we should proceed as philosophical practitioners. Peter will speak first with presenting his ideas about the use of diagnostics, conditionally speaking, diagnostics in philosophical practice. Then Oscar Brenifier will speak after him also in favor of philosophical diagnosis, while Lou Marinov and Detlef Staude will speak against the diagnosis. So each of them will speak with 10 minutes, and then we will have a discussion, an open floor discussion, where we would like you to get involved as much as possible. Before we start, I should like to thank Lou for the plenary lecture this morning and for agreeing to give this lecture, because originally he hadn't proposed to do it, and I asked him to do it, so he did it, and for all the discussion that ensued, and we can now start with the roundtable. So Peter, if you want to take the floor. Okay.
Is it?
You can speak freely. The microphones will catch it.
Okay.
You don't need microphone.
You don't need that.
Not really.
Just they will catch it.
This one's live. This is for the recorder.
Okay.
Yeah.
Okay.
It's okay.
Yeah.
Yes. So my name is Peter Hartelo. I'm a philosophical practitioner from the Netherlands, also called Holland. Two names for the same country. And before I entered philosophical practice, I was a medical doctor with a training in psychotherapy. So in proposing this concept of the philosophical diagnosis, I'm very much aware of the differences between the medical, psychological, psychiatric, DSM kind of stuff, that kind of diagnosis, and the philosophical diagnosis. I really want to propose it as a new, what you might say, alternative concept, and please don't compare it with the other ones, like in medicine or in psychiatry. Actually, I was inspired by this concept in two ways, you might say. The first was Lou Marinov, actually. By the work of Lou Marinov, because I I studied it, and I thought, hey, what's happening here? And I heard Lou talk about the cultural diseases and from a philosophical point of view, and I thought this might look like a kind of diagnosis, like a philosophical diagnosis. But then I found that Lou was very much opposed to the concept, so I might have misunderstood, and this is maybe the opportunity to clarify the issue further. And of course you might know that last year a new version of the DSM, which is the Diagnostic Statistical Manual for Diagnosis in Mental Health Care, was adopted, the DSM-5, which raised a lot of issues. Also in Holland, you might say that the Association of Psychiatrists rejected the thing. They rejected it as a classification that is unjustified in its labeling of persons being sick, and that it's too much, and I think Lou already this morning talked about it, driven by the pharmaceutical industry. So it's a rather and by a reimbursement, you might say. So it's a rather political instrument that it is now, which is not, you might say, considered very useful for the actual treating of patients. So I was inspired in that sense that I thought, well, if we as a philosophical community can come up with a critical alternative, something you might call a philosophical diagnosis, then in fact we are empowering what you might say the opposition against the current DSM, the DSM-5. So those two reasons led me to postulate this concept of the philosophical diagnosis, and I think also in order to begin this debate, we should be clear about the concept, because otherwise I've been to South Korea last month proposing this concept, and Peter Rabe came up with more than 18 points, 18 arguments against a philosophical diagnosis in order to crush this thing. But in looking at those arguments, most of them were aimed at, let's say, the medical or psychological diagnosis, or at the DSM, which is not the intention of this concept. And then in seeing him acting in a workshop, he was identifying informal logical fallacies in the speech of a person. So a person says something and say, this is blah 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 fallacy. This is blah 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 fallacy. I thought, that looks like what I'm intending to be, a philosophical diagnosis. Because what should it be? Do you think it worked like that? Otherwise, Lou, can you do the next slide, please?
I can try. Too many buttons. Let's try this one.
I think you may need to direct it up there to the projector.
Wrong.
You want to go back to you, okay?
I have to direct it. Otherwise...
Well, wait a minute.
Yeah.
How about that, Peter?
Yes. Push the button, please.
All right.
So, in order to be clear, so the philosophical diagnosis for me means, and that's the thing I see a lot of counselors and practitioners do, the identification of philosophical content in the speech, words, action, life of the client. So it's an identification of philosophical content. An identification of philosophical content that has to be captured in words, so that it's followed by a description. And that adheres, what I would say, to the original meaning of the word diagnosis here in Latin from the ancient Greek, diagnosis, diagnoskine, to discern, to take apart, but also from gikoskine, to learn. Next slide, please. What we find in current dictionaries, and here you see you might say the medical dominance of the term, is the identification of the nature and cause of something, / an illness in medicine. But also the second one, very interesting, a written description of a species or other taxon serving to distinguish that species from all others, especially in the Latin connotation, written and published. So in postulating the concept philosophical diagnosis, I intend to capture this original meaning of the word, again, as a critical function of the current medical use, you might say. Next slide, please. So then what is in it? The philosophical diagnosis. First of all, the identification of the nature and cause, that is the philosophical content of a theme presented by the client. Description of the theme in a philosophical way. It represents a philosophical lesson. Even if you identify logical fallacies in the speech of a client, you have to transmit that message to the client, and you present him with a lesson. It is, I think, very important, an explicit statement, so that we can work on it and with it, with a public character. Very important also to distinguish our practice from psychology, which is usually, you might say, some hidden private practice in some room. This adheres to the, you might say, Socratic meaning of going out into the marketplace, being able to discuss the theme of your client there, and to put it on the internet in movies like Oscar is doing. You know, it has to be a kind of public character. The next slide, please. In postulating this concept, also very important is that in teaching of psychologists, they usually ask you the question, what is actually philosophical about your consultation? And that's a difficult question. I felt it difficult to answer. But I think identifying philosophical content is our expertise. And that's one thing that distinguishes us from a psychologist or psychotherapist. Even, let's say, psychologists or psychotherapists that work in an existential way or something, I think their identification of philosophical content is limited. It's just, they don't have the broad overview, which I call here the dimensions of being, doing, and having. I picked this up from Sartre. Sartre says, what is philosophy about? Always, every question can be related to these kind of dimensions. Being, doing, and having. This also implies that the diagnosis is dimensional, so it's not being or doing or having, but these are dimensions of the philosophical diagnosis, and that's contrary to the medical use of it. In medical use, you speak of a categorical diagnosis. The patient has either a pneumonia or not, either schizophrenia or not. And in the current DSM-5, they're also trying to apply this dimensional approach, which led up to the result that everyone is schizophrenic for some percentage, you might say. But I think the philosophical diagnosis, in order to fulfill its critical function, has to be dimensional, has to be related to these philosophical dimensions of being, doing, and having, because then we capture, let's say, the philosophy in its very broad range. And coming more to what the client's actually saying, I distinguish several themes. I don't call them problems, like you would do in psychology or psychotherapy, but I prefer to talk of themes. The client in philosophy has a kind of theme. I distinguish existential themes, the themes of being, who are you, who am I. Foundational themes, persons looking for principles. Transitional themes, in life, you go from a young man to a worker to pensioner, you know, that kind of transitional moments are often encountered in philosophical practice. Cultural themes, I think then I refer to Lou with his let's say his cultural dis-ease, his diagnosis of the American society, and logical themes like in the example of Rabe, who is identifying fallacies in speech of his clients. So the diagnosis refers to philosophy on the one hand and to the theme of the client on the other hand, and thereby justifies our consultations as being really philosophical and distinguish it from psychological or psychotherapy. So next slide, please, Lou. Now, more or less anticipating the debate, some arguments in favor of the philosophical diagnosis. It is, I think, first of all, a concept covering something we do in philosophical practice. And I would like to invite even the famous philosophical practitioners at this table to demonstrate their thing, and then I think we can see a moment in Oscar's approach, in Marinov's approach, where they identify this philosophical content, and then they start working on it. But so there is something like a philosophical diagnosis in it. So it's something we do in philosophical practice, and therefore I think we can make it explicit by using this concept. We need it also in order to make, this is also an important argument, to make a philosophical consultation philosophical. Not necessarily, but it can be, in that sense, an instrument serving this function. So that means it serves communication among practitioners. Now I can call up Oscar and I say I have a very, very severe existential case here with being, and what would you advise me to do? You know, and then so we can communicate it in a more precise way, which means it enhances professionalism and the development of philosophical practice. In the end, my dream would be a kind of database with actual cases that we can approach for advice or inspiration. And in order to find those cases, we have to need some concepts. And those would be called a philosophical diagnosis. It has a critical function in a sense that it is an alternative to psychological diagnosis. It is no label. It is a construction that arises during a consultation. So that's also a very important difference between the psychological diagnosis. The psychological diagnosis is something in the head of the psychologist applied to the client. But I think this philosophical diagnosis is something that is constructed during the consultations. And recently we have a very interesting masterclass in Switzerland with Schlomit Schuster, who coined it actually as the term self-diagnosis. So it is the person, the client, actually him or herself, that is making up a kind of concept, serving that functions of identifying philosophical content, which is being facilitated by the philosopher. So she calls this self-diagnosis, and that's also, I think, very close to what I intend to mean by this term. Please, next slide, please. So often arguments against this philosophical diagnosis. Well, I learned this from Lou, that in the United States, it's very simple, they are not allowed to use the term diagnosis, because then you're sued or something, if you're not a medical doctor or trained in clinical psychiatry. That's not something we have in Holland, and I don't know in your country, in Europe maybe, and especially when we call it a philosophical diagnosis. I think there might be some problems if we speak about a diagnosis and it would be interpreted as being a psychological diagnosis, but if we were very clear this, no, this is something completely different. Philosophical diagnosis, we are allowed to use the term. There is, of course, the risk of the medicalization of philosophical practice if it is going to be used as a kind of labeling. It could be used as a label instead of that construction. It could be captured, misused by third-party payers, like it happened to the DSM. But then I think it is, if it is our instrument and we learn the lesson of what happened to the DSM, we are there to prevent it, you might say. But these are commonly arguments also framed by Peter Rabe against the philosophical diagnosis. Last slide, please. No, this is it. Well, remember that Peter Rabe calls his practice philosophical mental health care. But in the end, so he rejected this idea of the philosophical diagnosis. But I hope to have present my point. It captures the identification of philosophical content in the speech, actions or life of the other persons. So it's actually both a process, capturing that content as the outcome of the process. And the process is an interactive construction between client and practitioner.
Okay, Peter, thank you very much for an excellent introduction and an intriguing proposal. We move to Oscar's argument.
Right. Now. Thank you. I was asked at the last minute yesterday to replace Ree, who couldn't come, and I was told you have to defend diagnostic. So I will do my job. I'll be obedient. I'll defend diagnostic. I could have joined the others. It wouldn't bother me, but I'll try to play my lawyer's role in favor of diagnostic as much as I can. Tell me if I betray you.
Good lawyer.
So first, I'll make little distinctions, and then I'll move to something more substantial. First of all, I would like to distinguish diagnosis and diagnostic. Diagnosis is actually the identify a cause of a problem, illness, if you're a doctor. Diagnostic, there's an art of doing that. Personally, I'm more interested in diagnostic, the art of doing the thing, than the diagnosis in itself, because I think it belongs more to what is philosophical practice. But the distinction, more important, I would like to make from Peter is that he a bit avoided the problem question. It's about problems. But normally diagnosis is to find cause of an illness or a problem, right? Now, of course, in philosophy, it's easy because human existence is a problem. So we're not short of problems. Anything almost is a problem. So that could have, I don't know why he doesn't like problem, because we are full of it, and no problem, we don't do our job anymore. So we have to distinguish problem, right? On diagnostic, we're very open in France. Everybody does diagnostic. You have a car problem, you go to a car place and do a car diagnostic. So if you can do car diagnostic, you can do it on anything you want. It's a very popular word, and it's very open and flexible. So there's nothing dramatic, at least in France, about diagnostic. Now, let's go back to the problem. What is a problem? I tried a little definition within human being. I forget the car diagnostic. A problem is something which engenders fracture of being, uneasiness, preoccupation, pain, or practical difficulty. Right? I go again. Fracture of being, uneasiness, preoccupation, pain, practical difficulties. Now you might add some or say some are redundant, but basically I try to cover a bit what are problems in human beings as philosophical practice. So what we do is take care of that. How do we do this? With a very important philosophical competency called to conceptualize. Now, what is to conceptualize? Is to name some reality. You give it a name, either as a category or as a phenomenon. And we name things. I think if philosophy has one of the main preoccupation, main activity, to name things. We name things which normally are unnameable, that people don't name. They don't give names, right? We name the unnameable. What nobody else takes care of naming, we name. Right? Things which nobody or other people don't really worry about, or they worry about it, but they don't know what it is. So we name, we conceptualize. So we'd like to bring diagnostic simply as the art of conceptualization. And it should not be banned, because precisely philosophy names all these things that normally are not named. So if we ban diagnostic, we ban naming. So I think that would be a little bit of a problem. So this being said, I would like to show that it's inherent to the history of philosophy to do diagnostic, that we're not inventing anything, it's an old practice. I'll give you some example in the history of philosophy. Plato has a diagnostic. He divides souls between three types of soul: bronze souls, silver souls, and golden souls. How to distinguish them? Primarily through their capacity of reason, through their capacity to the width of their horizon, and their capacity to internalize laws. Bronze souls, you have to tell them what to do. Silver souls, they tell the others what to do. But the golden souls, they don't have to do this. See, the laws are inside of them. That's why he says they're almost gods. They don't need laws because it's inside of them. So he makes distinctions of souls. Another distinction he makes is between opinion, right thinking, and truth. Opinion is what we repeat and say every day. It's a diagnostic. People they just hearsay, they repeat. Right thinking are professors. They learn things, they repeat it, it's constructed, but it's still a right opinion, sorry. Not right thing, but right opinion. But then you have truth. Truth is for the golden souls. Truth is, there is nothing ever defined. You always rework it. It's always a process, right? So he listens to you, and he will identify, is it banal opinion? Is it true opinion? Or is it you're looking for truth? And that's the philosopher. He as well distinguishes ugliness and disease. Ugliness, you go see the gym teacher, it's ugliness of the body, problem with the body. And he says, if it's a disease, you go see the doctor, right? He has two kinds of therapies. Now, I have to be sure I won't go into the details, but he identifies types of diagnostic through that, right? For the Stoics, you have three types of problems of diagnostic: physical virtues, ethical virtues, logical virtues. And of course, if you have virtue, you have a default. That's a negative of it. So if somebody has a problem with a physical, ethical, or logical virtue, you have to deal with it. You have to educate this person, but you have to distinguish. And that's the idea of diagnostic, to distinguish. You have to distinguish the problem. For Descartes, what are the diagnostic which are a problem? Precipitation. You rush, you don't think. Confusion, not clear ideas, you can't think. Or accepting authority without questioning. I give you three of his main diagnostics which are a problem in the thinking. For Spinoza, sad passions that reduce the power of being. This is diagnostic which for him is a problem. For Kant, minority or majority. Are you in autonomy or heteronomy? Are you in confusion or clarity? Are you in a capacity to pose judgments with the adequate tools? Again, for Marx, ideology, a determined, fixed pattern of thinking. Some criticism about German ideology about that. How you don't think because you have an ideological structure. Hegel, unhappy consciousness. Man that always, which is interesting in Hegel because it's dialectical. It's both something that stops you, the unhappy consciousness, but at the same time, something which allows you to pursue some higher goal. And I'll come to that, but that's a very interesting aspect of diagnostic in philosophy compared to doctors, is that we can transvaluate it. It's a problem. So we can play both ways. It can be positive or negative. And I think that's a bit quintessential in the philosophical practice. For Nietzsche, good conscience, that's for him one of the worst diagnostic. Good conscience, or what corresponds to the last man, self-satisfaction, right? Or the great reason of the body in opposition to the small reason of the mind, right? Very critical, this diagnostic. Sartre, bad faith, right? The double-mindedness, or the double-heartedness, right? In opposition to authenticity that can be both deceiving others or deceiving yourself. Right? Very crucial. These are not secondary diagnostic. These are really important in the functioning of the human being. Wittgenstein and Pascal have something in common. No, you have to know what you're saying. And those people don't know what they're saying. They don't realize it. Very strong diagnostic. But you have some very opposite one. You know, in postmodernism, what is a diagnostic is any universal statement. That's the disease. Get rid of it. Or anything, or people then... This morning we had something about feminine and masculine thought. You know, historically, Feminine is bad. Now, for some people, masculine is bad. Okay, diagnostic. Now, you don't have to agree with the diagnostic, because diagnostics are based on a certain framework, on a certain ideological construction, on a certain vision of the world. Just like maybe doctors don't agree, but philosophers might not agree because diagnostic is based on a certain vision of the world, right? And just to change a bit horizon, in Zen Buddhism, in the diagnostic, you have to look for 4 things, which they call the 4 poisons: doubt, fear, confusion, anger. So when you see this, oh, it's not me, I'm jealous. Why him? Anyway, these are the 4 poisons that you have to identify in someone, and the teacher will have to identify it and work on it, right? So now, just to make some short distinction with psychological diagnostic to reassure our colleagues on this, right? First of all, it's not a science. There's no scientific pretension. It's an art. And like all art, there is a dimension of subjectivity, like in teaching music. A music teacher, he will work on the problems of his student, either technical problem, the moving of the fingers, or interpretation problem, right? But it doesn't pretend, I mean, he can, but normally that it's some absolute objective determination. That's his school of thought. Another distinction. See, the idea that we're not here to do the diagnostic, at least the way I work, people around me work, we invite the person to do the diagnostic. A psychologist doesn't say, hey, why don't you now do your diagnostic? Here's the book. Maybe he can, but generally they don't. So we invite the person, look at your behavior. Now, for example, you have a hard time. You say, well, I have a hard time to decide. Well, why don't you name it? You call it. You give it a name. And then you analyze it. It's called emotional intelligence, right? You invite the person. You can do it too, but preferably the other person has to become a philosopher. A psychologist doesn't want you to become a psychologist. Otherwise, he earns no money. But a philosopher, normally, he wants these clients to become a philosopher. So it's both reflexive and it's mutual. When we have seminars, we identify each other's characteristic, right, or diagnostic, and it's part of the process of training, right? In other words, it's more an indicator of difficulties, things to work on. Not so much to say, okay, here, that's what the problem is, here's the prescription, right? But you identify what an obstacle, again, like a music teachers. Last, I mentioned it already, philosophical pathologies, if we can call them this way, can be problematized. Because fundamentally in philosophy, there is something called autonomy, which in psychology is not really the preoccupation. There is the autonomy of the subject. Therefore, if somebody says, somebody discover he's unconscious, he lives in a Disney World. We have some people come to consultation and realize they still live in Disney World. Fine. I ask them, first of all, do you want to change it? Or you want to stay in Disney World? If you want to stay, fine. We'll look at the consequences, but stay there. So the person decides if they don't ask people, do you want to stay neurotic, right? So we ask them, do you want it? Because maybe this person is fine living in Disney World, but then all he has to do is be conscious of the problem. So there is free will, there is autonomy in philosophical diagnostic. Next one, capacity to transvaluate. In philosophy, nothing is negative a priori, nothing is positive a priori, except within a given framework. And that's a very important contribution of Nietzsche. To say transvaluation is a capacity to stay sane. If you have fixed idea about the good and the bad, then you say you're not thinking anymore. You have to be able to transvaluate. For example, somebody's unconscious and you think it's bad, well, think what's good about it. Well, maybe you'll be happier if you're unconscious. So the capacity to transvaluate is a capacity to think and as well connected to freedom. So we ask people to be able to transvaluate or redescribe what they see as a problem, right? So very important, but it's a thinking competency. So the final point, as a practice, we invite people to name, to analyze, to conceptualize their own behavior and their self. That's the idea of philosophical diagnostic, to conceptualize who they are, how they function, either through self-diagnosis or primarily, but as well through philosopher diagnosis. But I think the crucial point to come to that, which I use as a conclusion, is that diagnostic in a philosophical practice is neither descriptive nor prescriptive, is performative. For example, if I tell someone gets angry when I question him, and he's angry, I say, why are you angry? Now, what's going to happen? It's not so much if I qualify him as angry, but I see how he's going to react. He's got a performative dimension. That's in a lot of the Socratic dialogue. People say, oh, he makes logical mistake. Doesn't matter. It's performative. You say something, and you will see how the other person deals with it, with his argumentation, his position, and all this. And I think that's a big difference, and that's why it's part of the dialogue. It has a performative dimension. It feeds the dialogue instead of closing it like if it was a prescriptive or something normative as a descriptive or prescriptive determination. So basically, that's it.
Oscar, thank you very much, and thanks for making this distinction between diagnosis and diagnostics. I think it's potentially great material for discussion. Let us move to the other camp in the argument. Who wants to fire first?
I have prepared some paper, and so I tried to read it. I hope it won't be too difficult. So, we are familiar with the term of diagnosis from medicine. Peter, who studied medicine himself, had the idea that diagnosis as a methodical search for differences and conclusions might be suitable for philosophical practice as well, and might help us to become more professional, as he said. I support everything which can promote professionalism in philosophical practice, but we have a very old problem in philosophy. Concepts differ from person to person, at least slightly. So every philosopher starts with the definition of his or her most important concepts. Therefore, the comparison of different philosophies is not so easy because they are all built on different concepts. Diagnosis, so Peter supposed, could be a tool that makes more easily comparable the different ways of philosophical practice, as well as the typical situations of persons who come to us. But who is going to establish the main categories for this diagnosis? If everyone uses...
Can you speak up?
Could you pass the microphone?
Yeah.
The microphone.
The live one. The live one.
Okay.
You have to speak up anyway.
If everyone uses their own categories, the situation is similar than without diagnostic categories. If just a few of us develop the categories, they will hardly fit for all of us and our ways to see typical situations of people in philosophical practice. So I think to develop such categories is an interesting work for those who do it, but it will not be of the expected help for philosophical practice as a whole. Nevertheless, even if I am very skeptical about diagnosis as a helpful general tool for philosophical practice, comparable to the worldwide unified use of medical diagnosis, perhaps the idea and perhaps possible categories are a fruitful philosophical task for us. Because it makes each of us reflect on similarities and differences in dialogues which he or she has experienced in philosophical practice. And this, perhaps, brings us to a clarification of our own methodical concepts. So instead of my skepticism, I try to sketch what diagnosis in philosophical practice, from my point of view, can be positively. what can diagnosis mean in philosophical practice? Diagnosis is meant as a tool of cognition in order to find out the gestalt fitting for the dialogue in philosophical practice. Different to the medical use of the term diagnosis, in philosophical practice it does not hint neither to a treatment nor a certain mode nor goal of our common reflection with the visitor, because philosophical practice has, according to the Aristotelian understanding of praxis, no aim beyond itself. That means philosophical practice isn't therapy, but open dialogue. In philosophical practice, this dialogue is focused on the person's personal situation. And this situation has to be researched in the field concerned. Looking at the philosophical consultation, this field is outlined by the visitor in the beginning, when he tells us the subject or problem which he wants to talk about. Afterwards, the important concepts we got to know in the beginning are deepened and help us to gain an impression of the visitor's life situation in the concerned field. If we are putting this into words, we have the first diagnosis. We recognize the challenge the visitor and practitioner have to face and what will be the core theme of the dialogue. As philosophical practitioners, we are unable to make an examination with our visitor in the beginning. We have no diagnostic instruments, but comparable to them are the philosophical concepts. For instance, justice, freedom, truth. In a consultation, I can say quite early whether, for instance, justice is the main subject, or identity, or the meaning of life. We would call this main subject or core theme the diagnosis. But such a diagnosis is a fairly general in the beginning and can easily lead wrong. Even if one speaks about the same thing, one may miss the adequate diagnosis, and that means that the philosophical practitioner not really understands why the visitor has come to him. Perhaps even he himself doesn't want a problem to be solved, but wants to have his values well-founded. The existential problem then would just be the inducement for that. So we have to become clear about the visitor's true intention as well. This can take some time because he himself may be not so clear about that. The diagnosis in philosophical practice is a process going along with the dialogue itself. Similar to a spiral, the diagnosis is again and again put into question and enriched with new aspects. Different to medical diagnosis, it stands not at the beginning of the practice, but at the end of the consultation process as a whole. Unlike the medical environment, there is no expert who uses his knowledge to diagnose which problems the visitor has and by doing so shows the way, but the philosophical practitioner joins the visitor on his dialogic path to become clearer about aspects of his life situation. On this path, the diagnosis is a hypothesis for the direction of the search. It might be corrected, enriched, or made more precise, but it is useful from time to time in order to direct and readjust the process. In the end, we know quite exactly what it was all about, but by knowing this, the life situation has already changed. And one has become freer, also free of diagnosis. Understood on a meta level of reflection, this means in a philosophical dialogue, we are concerned with the personal situation of the visitor and also with the personal situation of the philosophical practitioner who tries to keep aside too much personal involvement by preserving a philosophical level. A situation, as the philosopher Hermann Schmitz defines it, is a chaotic, manifold wholeness with no single issues. So we don't have a certain number of exact definable issues which altogether make up the situation, but every issue or subject or problem which is part of the situation is it together with an undefinable number of others. The understanding of the situation, therefore, can never be fully, but in the field in focus one, in the field in focus one, and by the philosophical and biographical knowledge which one has as a human being and as a philosophical practitioner. So in the end, when the diagnosis has become most exact in the course of the dialogue, the situation changes and the problem vanishes. Now we don't need the diagnosis anymore, just perhaps for your own retrospect of the path which the dialogue went. So I think it's just a concept for us, but it's not really needed for our work.
Okay, Detlef, thanks very much. And the last speaker in the panel, Lomera.
Thank you very much, Sasha, and to the three panelists for the perspectives. I want to begin by saying that I'm in a conceptual way only, not as opposed to this idea as some of you may think. Peter and I have worked together before, and I think well in some ways, and we agree on a lot of things. Privately, I could see that there might be some conceptual use for this in terms of the original meanings of the words, and I'm on the record also in fighting this same fight in a different context, in saying, for example, that the word therapy in ancient Greek meant an attendant in a more generic sense, so someone who parks your car is a car therapist, someone who looks after your dog is a dog therapist, so why can't we be, therapists in that sense? So I sound like I'm on your side, but I think in a very practical sense, we need, again, we're on the edge, so in a conceptual world we could have this conceptual debate about the value of the equivocation which is being created by Peter's proposal, because it is an equivocation, two very different meanings of the same term. And we could also have an internal debate, as we've had over the years, about what we call ourselves and what we call our clients and what we call our work. And this has traction, because when we come to do it, you have something on your business card, something on your website, something that the public identifies as the nature of the service they receive from you. And this is where I think we would err very gravely in calling ourselves diagnosticians. So in a conceptual way, I'm very open to the debate. In a practical way, I think it would be a huge mistake at this time. I'm only saying at this time. And I think that is really more of a professional and a political question. How does the public perceive our services? What does the public think differentiates us from psychologists, from psychiatrists, from the medical profession? And how, as a profession, Are we going to get more clients and not fewer clients? And what is the best way to remain authentic to our own philosophical principles? And you and your own toolkit, and also to present yourself in a pragmatically useful light. So my objections to this are going to be grounded in an American context, because that's where I mostly practice. And I just want to highlight what the problems would be immediately if we began to say that we made philosophical diagnoses in the USA. Europeans in many ways are freer. I mean, we have this wonderful thing called the First Amendment, and Americans are very, defensive about, liberty, and we say, oh, liberty, liberty, we're the freest people, but we're not. I have to say, living there 20 years, I find a lot of lip service is paid to liberty, but there are dire restrictions that have been placed on speech. The university have speech codes in place, which are complete refutations of the First Amendment, and there's been an appropriation of language by the medical profession, which is ongoing. Sam Brown in the UK just did a yeoman's job in getting the government to drop a piece of legislation that would have appropriated the word counselor and made it only the property of licensed psychologists. And Sam Brown wrote a brilliant paper explaining there have been 18 different meanings of the word counselor in history, and none of them were psychological. So it was, again, a question of education. So here's my objection, to this. There used to be a joke that psychiatrists told in the United States, and the joke went like this: that patients who came early for an appointment were diagnosed as anxious, and patients who came late for an appointment were diagnosed as hostile, and patients who came on time were diagnosed as compulsive. Yes, now they laughed at this joke also because it was only a joke. They were using language in a figurative way, not in a literal way. But I'm sorry to say that due to Orwellian and other, untoward developments in the use of the English language and the politicization of the English language, in the United States at least, there has been a great blurring of the distinction between literal and figurative speech. And most Americans I deal with, whether they're university administrators or ordinary people, they are literal-minded to a fault. They take the face value of words as their meaning. And because the medical profession has been so successful in appropriating terms like therapy and treatment and diagnosis, not only the connotations, but in people's minds, the denotations are almost exclusively medical. So on the one hand, I would be, in a conceptual way, sympathetic to wanting to reclaim the turf and point out the broader meanings of these terms, both historically and conceptually. But in a practical vein, I cannot invest a lot of time in that battle because I think it's the wrong time to fight. What is happening, on the other hand, is that the whole medical edifice, based on these spurious diagnoses and knee-jerk medications of people, is beginning to collapse. And I suggest the wiser course as practitioners might be to watch that happen, and then to remind people that we were objecting to this 15 years ago, and some of us got into a lot of trouble for doing so. And now it turns out that we're being proved correct for not adopting these terms, and in fact for standing against the diagnosis and the medicalization of all human problems. And I think that the best course in America in general, at least, would be to remain consistent. And here's some evidence, okay? For example, in April of 2013, this was really important because it is not the APA, Peter, that rejected the DSM-5. The APA creates, the American Psychiatric Association publishes the DSM. It's their Bible. Yes, they have recalcitrants like Irvin Yalom who transcends it and who rejects it, but it's their publication. It was directed by the National Institute of Mental Health. Folks, the NIMH is the largest scientific organization in the world dedicated to research and treatment of mental illness. They're a U.S. government agency. They have repudiated the DSM-5. They said we're sick and tired of seeing symptoms diagnosed as if they were illnesses. And what they're asking for now is good science. They're saying we want etiology, we want causes, we want pathways. If you're going to make a medical diagnosis or a psychological diagnosis, we want the biological substrate to be explicated. We don't want symptomology. That's coming from the NIMH. The New York Times, in March of last year, published a scandalous piece in which they reported that the pharmaceutical industry itself was the primary cause of ADHD, and that they were propagandizing and making parents afraid that their children needed to be drugged in order to perform well in school. And so this whole business of ADHD diagnosis is now, even by the Times, being reported as a kind of scam that's perpetrated by the pharmaceutical industry. In June of 2013, the World ADHD Congress, this was like the 6th World ADHD, 2,000 people who make a living diagnosing and researching and treating ADHDs, had a plenary debate, and they asked the question, is ADHD a valid diagnosis? They mean sound when they say that. They're questioning it themselves. So this kind of diagnostic culture is now starting to collapse from the inside, and there's media pressure against it. So the word diagnosis now is being questioned by Americans. So I think it's really, for us, the wrong time to be picking up this word and trying to utilize it ourselves. I think we need to let it slide into further disrepute before we attempt to recover it, as an authentic and ancient term. It's really just a question of timing. But there's a couple of other objections too. 2 minutes. Philosophy and medicine are complementary but distinct. When medicine works well, it really carves nature at its joints. It identifies something which is ontologically sound and seeks to remedy it. We don't do the same thing at all. And I want to underscore what Detlef said. We do not work with diagnosis, we work with dialogue. If anybody asks, what do you do as a philosopher? Primarily, I would say dialogue with clients, with groups, with others. And this is what has saved us, if anything, in the US, against charges of we've been accused of practicing medicine without a license, practicing psychology without a license, all these things. We say we don't diagnose. That's been one of the mainstays of our differentiation from the diagnostic professions. We don't attempt to it. We're not trained. Peter, you are. You're a doctor and you're trained. Maybe it's for you, it's a natural thing to segue into philosophy. But for us, the distinguishing factor is dialogue. Also, people have been, as we understand, dehumanized by rote medicalization and pathologization of their problems. They've sought refuge in philosophy, many of them, where they are not judged, not diagnosed, not regarded as pathologically problematic. Now, if we start adopting the word diagnosis, I'm afraid we are going to end up doing what you suggest, which is actually medicalizing what we do. The last refuge for some people is going to end up being part of the problem, not part of the solution. So I think, in a sense, it may be nobly a good conceptual thing to reclaim words and remind people of their original meanings. I wish we could call ourselves philosophers. Why do we have to call ourselves practitioners? Because in the ancient world, philosophers did all the things that we do. And the word philosophy has come to mean something different. People understand by it an academic term, yeah? Why can't we just call ourselves philosophers? When we could just call ourselves philosophers again, and people will understand that that entails practice, then we could probably diagnose too, Peter, on a safe ground. But in the meantime, I look forward to that day also, and I'll join you. In the meantime, I think there's nothing wrong with having a taxonomy of philosophical problems. That's not prejudicial, that's not medical, that's not appropriated. We could certainly effectively and usefully deliberate among ourselves and create a taxonomy of problems, a categorization of problems, without resorting to this misleading equivocation called diagnosis. And I will end there.